good, and I'd like to thank you for the opportunity to participate in this Congress and share our experience about the treatment of brain AVMs. I'm going to talk about some insights about this treatment. This is my group. We work in São Paulo, Brazil. We have evolved from one period when we used glue and achieved very bad results in terms of cure until now, when we have the non-embolic, non-adhesive agents as onyx and squid, and now we have much better cure rates. Over time, using this kind of embolic agents, we have achieved better results in terms of cure and in terms of controlling all our complication rates. For this, we have to know the principles of this treatment. The main principle is to achieve intranasal occlusion with this kind of agents. In the non-adhesive embolic agents era, the injection time is no longer an issue compared to glue era. With this kind of embolic agents, we need fewer pedicles. We have a more efficient filling of the nidus, but still in the literature, the cure rates are variable. The main danger of this treatment is to achieve an incomplete nidus occlusion with vein occlusion, with the danger of leave and residual hypertensive nidus and cause hemorrhage. Basic concepts of this treatment is to cure the AVM only by endovascular approach. Usually we put a microcatheter in the intranasal position to and control the reflux is an essential point to achieve a controlled filling of the nidus until at the end occlude the vein. Let's see an example where this is possible, but to highlight some risks of this treatment and to explain why we have evolved for some variations of the technique in order to control the venous filling. This is a cerebellar brain AVM in a young patient who have presented a rupture some months ago. In this patient, we used the radial approach. This is the radial puncture, usually using the ultrasound, the introducer, the navigation of the catheter until the vertebral artery. This is the angiogram showing the angioarchitecture of the brain AVM, showing the arterial feeders, the nidus, and the draining veins. After the study of the angioarchitecture, we plan the treatment. In this case, we have chosen one main feeder to perform the embolization only by arterial approach. Here we can see the navigation of the microcatheter until they reach an intranasal position. Usually, of course, we use a detachable microcatheter. Then the injection of the embolic agent, progressively filling all the nidus and excluding all the avian. This is the control, showing that we don't have the nidus anymore. The retrieving of the microcatheter, then with only one injection from arterial approach, we can reach complete occlusion of the avian. Angiographic occlusion of the avian. This patient woke up very well. We kept her in ICU for 2 days, then more 5 days in the hospital to surveillance. She was discharged without deficits, but 1 week after the procedure, she had a headache and came back to the hospital. And the CT scan showed a small hemorrhage at the near the nidus, even with the angiographic cure of the avian by endovascular approach. This approach. And what is the problem? What happened with this patient? Why did the bleeding happen? Of course, we couldn't see very well, but some nidus may be left circulating inside the avian, but the draining veins were occluded. Then we had hypertensive nidus causing the bleeding. This is one problem of performing this kind of treatment, especially using just one feeder to occlude all the avian. Why it happened? Let's see an avian, which is most of the cases that have more than one feeder. When we use only one feeder, we inject, we fill the avian, and the other feeders keep the flow of blood, making difficult to have a homogeneous filling of the nidus, and maybe sometimes we can occlude the draining vein, leaving some nidus unoccluded, and it is hypertensive and can cause the hemorrhage. This happened with this last patient. Then this kind of feeling, which is not homogeneous, can cause bleeding. And how we manage this problem? We can, and we do now, perform more than one microcatheterization and injection simultaneously from multiple microcatheters in order to control this feeling. And now, when we have more than one feeder, we usually catheterize all the feeders to make more control in the filling of the brain avian, and reach the vein only at the end of the treatment. We described this technique more than 10 years ago as the double catheterism in order to control this filling of the nidus. And in 2021, it was described an even more aggressive technique using multi-catheters, more than two, in order to achieve this control. Then that is what we do in these days. This is a way to control the feeling of the nidus and reduce the risk of leaving the hypertensive nidus. Let's see another example on a small AVM that had 3 main feeders. In this case, we have chose to use the microcatheterize all the feeders at the same time. Then we put a catheter in the left internal carotid and another one in the vertebral artery. This is the setup from the catheter in the internal carotid artery. We advanced 2 microcatheters in the 2 main feeders. Then from the vertebral artery, we put another microcatheter in the main feeder. This is the strategy. 1 microcatheter from the PCA, the posterior cerebral artery, and 2 microcatheters into the main feeders in the MCA. Then we can have see the setup, 2 microcatheters from the ICA and 1 microcatheter in the PCA. 1 microcatheter in the PCA. Then we advance the microcatheter into an intranidal position. Then the other catheters in each main feeders from the MCA. Advancing the first microcatheter, the second microcatheter, then before the injection we have 3 microcatheters in place. Then we start the injection from the 3 microcatheters at the same time. In this way, we have a reflux in the 3 feeders, and the nidus pressure decreases. It is decreased, and we can have a much more homogeneous feeling of the nidus, and we can reach the vein only at the end of the procedure. This way, we can guarantee much more safe treatment. And here you can see the complete feeling of the nidus after the end of the procedure. After the procedure, we retrieve all the microcatheters. As you can see, all detachable microcatheters. First, we detach the PCA microcatheter, and then we detach the other 2 microcatheters. And the detachment of the third one. The final control shows a very homogeneous feeling of the nidus and a complete cure of the AVM. lessons we have learned with this kind of technique? If we control all the feeders during the treatment, we can decrease the nidal pressure, reducing the nidal competition, and having a more homogeneous feeling of the nidals. Usually, in our experience, we don't put more than 3 microcatheters at the same time. When we have more than that, we prepare with some previous session for a last session using multi-plug in order to cure the AVM. Then we usually use the multiple catheterization only at the final session. Of course, we have learned in the last years that the venous approach is a powerful tool to deal with brain AVMs which don't have safe arterial access. It is very safe. It is demonstrated in the literature. We have several articles, some of them performed in our centers that was published. Then we have learned that the venous injection is very effective in the filling of the nidus. But the danger is the rupture of the nidus if we have a venous occlusion before the complete occlusion of the nidus. And we have to choose very well the indications for this treatment. Professor Munae have talked about extensively of this technique. And how we can prevent early occlusion of the nidus. Avoiding competition and controlling the flow. We can do that in several ways. I'm going to show you how we can manage to control the flow, injecting from the vein and controlling the arterial side also. This is the first example, thalamic ruptured AVM. We can see an AVM fed only by the anterior choroidal artery, which is very dangerous to embolize, but a small nidus and just one draining vein. In this case, we put a catheter in the arterial side in the right ICA, another catheter in the vertebral artery only to perform angiographic controls, and a puncture in the jugular vein to access the venous side. This is the setup. We can see here the feeder from the anterior choroidal artery, the small nidus, and the vein. In this case, we are going to use the vein to embolize the artery. But to control the arterial side, in this case, where the arterial feeder is not safe, we can control it using the balloon to decrease the pressure of the incoming artery to the nidus. In this case, where we had a large vein, we can enhance the filling of the nidus from the vein using a technique called the venous pressure cooker. When in this case we put two microcatheters, one in the nidus and one a little bit before, The catheter in the nidus is used to inject the embolic agent, and the catheter before is used to put some coils to slow the flow in the vein. 2 microcatheters and a balloon to control the incoming artery. This way we reduce the arterial flow and enhance the penetration from the venous side. Here is the coils in the vein a little bit before the microcatheter put it in the intranidus position. The coils. Then, with the balloon inflated, we inject the embolic agent. As you can see, the coils hold the material that is kept in the vein. Then enhancing the penetration from the venous side. First, we fill the vein trunk, and after that, the embolic agent enters in the nidus backwards until we have a complete occlusion of the nidus from the venous side. This is the final aspect. And the control angiogram showing a complete occlusion of the AVM only from the venous side. Last case, we have learned that we can use both multi-plug arterial approach at the same time of the venous approach, using the best of each technique and controlling the flow in a much more effective way. This is an example of a large AVM rupture that we have treated twice in two sessions to reduce the size of the nidus and the size of the veins. This is the aspect before the third embolization with a partial occlusion. And at this time, we have 2 main feeders and 1 main draining vein. This is perfect to perform a control from the arterial side and from the venous side. What we do in this case? Then we use the multiple catheters in the arterial side at the same time of a venous pressure cooker, injecting at the same time from the arterial side and from the venous side, creating a reduced nidus pressure and a good environment to the nidus aspirate all the embolic agent, creating a nidus aspiration effect. What is the setup in this case? We put it 1 catheter, 2 catheters in the carotid artery to perform the microcatheterization of the 2 main feeders, and a puncture of the venous jugular, of the left jugular vein to perform the venous pressure cooker. Then, first, we put a microcatheter in the nidus position and 1 a little bit before to put the coils. This is the setup. And then we are going to put 1 microcatheter from the ACA and one microcatheter from the MCA. This is the final setup. Then we have before the injection 4 microcatheters in place. 2 arterial for injection of multi-plug injection, and 2 from the venous side performing a venous pressure cooker. We are going to put in this way we have all the control, creating an aspirative effect of the nidus with a very homogeneous feeling of the nidus. Then some coils before the venous injection. That what we did, we started from put some coils to create the venous pressure cooker. Then we started to inject from the arterial side, occluding the main feeders, creating a reflux, then reducing the nidus pressure, and then injecting also at the same time from the vein. And creating an inspiration effect, filling all the nidus. This is the injection, all at the same time from the arterial side, multi-plug arterial side, and from the vein. We can see the feeling, very homogeneous feeling of all the nidus. In this way, we can achieve a very safe or complete occlusion of the nidus without leaving no hypertensive nidus with potential, which is a potential source of bleeding. Then the message we can today, we know after several years using non-adhesive embolic agents that we have a lot of techniques that we can choose to personalize the treatment based on the architecture of each AVM. And the main goal is control the flow of the feeling. The final take-home message: to master brain AVMs treatment, you need to understand and to control the intranidus flow and feeling. I'd like to thank you again the opportunity of talking about this subject, which I like very much, and thank you again. Bye-bye.